Hi, how are you, everyone? Good evening. Thank you all for joining us. My name is Annie Benzie. I am the chair of the Fellow Subcommittee for SSAT, and I'm so excited to kick off a new year of our SSAT Complex Gastrointestinal Surgery Fellows Grand Round series. This is something that we'll be having every month. And joining us this evening, I would also like a special warm shout out to all of our international SSAT members from Ecuador. I think that's incredible, and thank you all for joining us as well. So first, I'd like to introduce our moderator extraordinaire, Dr. Charles Binkley, who is the most intuitive AI kind of person I have ever met personally. And he's actually my colleague at work too. So thank you so much for joining us. He's the Associate Professor of Surgery for Hackensack Meridian School of Medicine here, well, not here, but in New Jersey, as well as the Director of Bioethics for the network as well. So thank you so much, Dr. Binkley, and you can take it away, please.
Great. Thank you, Dr. Benzie. And thanks for the opportunity to moderate this evening. It's my pleasure to introduce our speaker, Dr. Brittany Mead, who is the Advanced GI and Minimally Invasive Surgery Fellow at Carolinas Medical Center. Dr. Mead grew up in Colorado Springs, Colorado, and went to medical school at the University of New Jersey. She completed her residency at Rush University Medical Center and the J.H. Stronger Cook County Hospital. And after finishing, she's now, as I mentioned, the Minimally Invasive Surgery Fellow at Carolinas Medical Center. Dr. Mead will be speaking this evening on the role of artificial intelligence in ventral hernia repair. Dr. Mead.
Good evening, everybody. My name is Brittany Mead. As Dr. Binkley said, I am the current minimally invasive surgery fellow at Carolinas Medical Center. My program director is Dr. Todd Henneford, and I'm very happy to be the first fellow presenting in the SSAT Grand Rounds on the role of artificial intelligence in ventral hernia repair. So Dr. Binkley stole a little bit of my thunder here, but I grew up in Colorado Springs, Colorado at the base of Pikes Peak. This is a picture from Garden of the Gods. It was a very nice place to grow up. I actually went to medical school at the University of New Mexico, go Lobos. I did complete my general surgery residency at Rush University Medical Center in Chicago, and we did spend half of our time at John H. Stroger Cook County Hospital, which is one of the oldest county systems in the country. And was fortunate enough to match at Carolinas Medical Center for my minimally invasive surgery fellowship. So today I want to introduce deep learning and the concept of artificial intelligence and talk about why the complex field of abdominal wall reconstruction is a great application for this technology. Then I want to share a little bit with you about our journey towards predicting surgical outcomes with AI at Carolinas Medical Center and close with a discussion of why it all matters. So let's get started by talking a little bit about artificial intelligence. This concept dates back to 1956 when a group of scholars at a conference in Dartmouth coined the term artificial intelligence. And this was kind of the first step in studying how machines simulate human intelligence activities. And we all know that since that time, the idea of AI has been super popularized by mainstream media with all of these iconic movies like I, Robot, Bicentennial Man, and of course, The Terminator. But AI has also gained some steam in the scientific community as well. You can see that in 2016, there were only 29 publications that pertain to AI in surgery, whereas last year we were talking about over 2,000 publications. So this is clearly something that is of interest in multiple areas. In an effort to make this interactive per request, there are 4 main applications of AI in medicine, and anyone is welcome to jump in and guess what the 4 main things we use AI for in medicine are. Otherwise, I will just continue.
Decision making.
Yeah, absolutely. Specifically, there are 4 kind of main ways that we use it in diagnostics. The first one is detecting lung cancer on CT scan. Radiologists use this on a daily basis. The second is reading EKGs. We're obviously doing that constantly. classifying skin lesions in our dermatology clinics, and identifying retinopathy on retinal imaging. So these are all things that we're very commonly used and very familiar with. And so the question is, why use AI in medicine? And we all know that diagnostics is an arduous and time-consuming process, and that in a lot of fields, the demand for experts really exceeds the supply that's available. And these deep learning algorithms can make diagnostics cheaper and more accessible. In addition to that, it reduces human error, increases efficiency, and is ultimately data-driven and objective. I think that EKGs in particular is a great application of artificial intelligence in medicine, because this is something that we use so frequently. Estimated 3 million EKGs performed annually in the US, with a market expenditure of $200 million in 2015 for EKGs. And the computer is very sensitive at interpreting sinus rhythm. So this is a great way for the computer to kind of fill in where experts may be kind of at their max for interpreting these basic EKGs, and also cut down on medical expenditure. So why ventral hernia? Well, this is a growing field with increase in surgical treatments, especially with rates of cancer going up and needing surgical procedures for those treatments as well. We have a growing number of ventral hernia and increased complexity of those ventral hernias. There are all kinds of new techniques that are requiring tailored approaches, and these approaches are not standardized between institutions. A lot of the patients have multiple comorbidities, and unfortunately, we have high recurrence rates. So in essence, there's a lot of room for error, and this is a great area to utilize machine learning to help us make good decisions, adequately prepare patients for appropriate operations, and predict surgical outcomes. So our first step towards predicting surgical outcomes at Carolinas started with complex data analysis. And that started in the area of chronic pain after inguinal hernia repair. So we know that this is a problem. Approximately 15% of patients experience growing pain 6 months after inguinal hernia surgery. But the current surgical recommendations continue to include the use of mesh and mesh fixation and repair, both of which we know increase risk of pain. And chronic pain, as we know, can be costly and difficult to treat. So the question that we asked is, could we predict who will experience chronic pain after inguinal hernia repair? And the answer was yes. So we created the Carolinas Equation for Quality of Life, or the SQL app, that predicts the incidence of chronic discomfort following inguinal hernia repair. And the patients or surgeons simply answer 19 simple questions about themselves, the hernia, and their current quality of life status as it relates to their hernia, answering questions like, do you have pain while coughing, walking, laying down supine, and is your movement limited because of pain? And then the app generates a percentage chance of having some form of discomfort 1 year following surgery. And we looked at 1,700 patients and over 1 million data points to accurately predict this. And this was really a game changer in outcomes prediction, because it provided surgeons and patients with a powerful education tool about inguinal hernias, their treatments, and what to expect after surgery. And what was so great about this application is that it took lines and lines and lines and lines of code and formatted it into a simple app that you could access on your phone, which made it really usable. And that was so groundbreaking in the field that it was published in the Wall Street Journal in 2014 to highlight the importance of educating patients about possible risks and rewards of surgery. And we followed this with a second app that was called the CEDAR score, the Carolinas Equation for Determining Associated Risk. And this was this was an app that was created as a predictive model designed to calculate the risk of wound complications following ventral hernia repair, as well as the related medical expense. It was designed by analyzing prospective data and multivariate logistic regression to identify the key risk factors for surgical site infection after ventral hernia repair. And you can see those listed here. So as well as their odds ratios. So obviously smoking, obesity, diabetes, previous hernia repair, any ongoing infection, if you were to make an enterotomy during surgery, and if the patient requires a component separation. And what's so cool about this app is that it provides a platform for physicians and their patients to discuss how certain comorbidities affect not only the outcome of their surgery, but cost as well. So for example, in an average BMI patient who is diabetic and is, say, a smoker,
They said, I know you'd rather be in the OR because that's where all good surgeons would rather
Of
be.
course so. I'm in the meeting.
Dennis,
sure
you may
that-
want
Sorry,
to
that's why I'm
mute
saying.
your
Could I ask everybody to mute their microphones, please? Thank you.
Sorry, y'all. So for an average BMI patient who is diabetic and is a smoker, you can see that their average risk of complication is 23%, with in-hospital charge around $4,600 and a follow-up charge close to $11,000. But you can sit there and you can talk to the patient and show them that if you stop your tobacco use, that reduces your risk of complication by 10%, as well as your in-hospital and follow-up charges by X amount. And so what the purpose of all of this is to streamline this complex data analysis and make it actionable. And our next step in outcomes prediction focused on CT volumetrics. So this paper that was published by Katie Schlosser, who is one of the research residents here at Carolinas, kind of addressed the fact that we know BMI and hernia defect are strongly associated with outcomes after open ventral hernia repair. But what we don't know is how the specific distribution of a patient's fat, i.e., is it the sub-Q fat, the intra-abdominal fat, is it the hernia fat, or how the ratio of the hernia volume compared to the intra-abdominal volume contribute to outcomes. So she looked at almost 1,200 patients from the time period of 2007 to 2018, who all had a CT scan within 1 year of their repair and completely imaged the abdomen, pelvis, and hernia, and primarily looked at wound complications. They also looked at things like reoperation rates, readmission, reoccurrence, total charges, and length of stay. And this is an example of how they did that. These are axial cuts of a CT abdomen, and you can see she measured the subcutaneous fat you can see in dark blue here, the intra-abdominal volume, which is this dark green area here, and then the hernia volume, which is this bright green area here with the contents outside of the abdominal wall. You can see the rectus and oblique muscles here. And then they also measured the ratio of hernia volume to intra-abdominal volume. And that measurement, the hernia volume to intra-abdominal volume, has been used as a surrogate to identify patients with loss of domain, which is really important when you're thinking about open ventral hernia repair. So because there was a really high degree of multicollinearity between the markers of hernia dimensions and that fat distribution, they did a principal component analysis to create new component variables, which included the CT measurements and BMI. So they came up with three main components. The first one was the hernia principal component, and that primarily reflected the hernia size. So the volume of the hernia, the defect size, and then that ratio we discussed of hernia volume to intra-abdominal volume. The second principal component was the extra-abdominal volume, and that was represented by the sub-Q fat and BMI. And then the last principal component was the intra-abdominal volume, and that reflected just intra-abdominal volume. And what we found was that the hernia principal component was consistently associated with all the measured outcomes, including intraoperative interventions of component separation, performance of a paniculectomy, achievement of fascial closure, and time in the operating room. The extra abdominal volume component, which again reflected the subcutaneous fat and BMI, was associated with paniculectomy as well as wound complications, which is right in line with what we would expect. And then finally, the intra-abdominal volume primary component was not associated was not associated with as many of these outcomes. And so this study emphasized the importance of a patient's hernia dimensions, their subcutaneous fat distribution, and the ratio of hernia to intra-abdominal volume when you're preparing a patient for open ventral hernia repair, because while BMI may partially predict obesity-related complications, a better understanding of the patient's specific fat distribution can allow better preoperative optimization. So the next problem we wanted to look at is respiratory complications that occur after abdominal wall reconstruction. And this has been reported in the literature of rates up to 16 to 20%, and hypothesized to be associated with increased abdominal pressures, intra-abdominal pressures once you return the viscera into the abdomen, smaller respiratory volumes, increased PEEP after fascial closure. And we know that the development of respiratory failure increases the risk of other immobility-related complications, including things like ventilator-associated pneumonia, urinary tract infections, pulmonary embolism, pressure sores, discharge to sniff, and even death. So given the high risk of complications associated with respiratory complications, we wanted to see if CT volumetrics could help us predict who might develop respiratory compromise post-surgically. So in this study, we essentially asked, can we calculate abdominal volumes, and does that impact the risk of postoperative respiratory insufficiency? When we use that same group of CTs, and this time looked at, again, development of respiratory insufficiency, and that was defined as a new persistent oxygen requirement that necessitated more than 1 day of supported BiPAP or CPAP, where respiratory failure was defined as continued mechanical ventilation for more than 24 hours after surgery, and or need for reintubation and mechanical ventilation at any point during the initial hospitalization. But those patients who were successfully extubated within 24 hours of surgery were not considered to have respiratory failure. And so what did we see? We found that in our patient population, 8.3% of patients developed respiratory compromise after surgery. 4% of those had respiratory insufficiency, and 4.3% of those required reintubation. And that the patients at the highest risk for respiratory insufficiency included patients with a high BMI, asthma, diabetes, and COPD. And that patients with larger defects greater than 200 centimeters squared, as well as patients with that large ratio of hernia volume to intra-abdominal volume greater than 0.5, were also at significantly increased risk. And identifying these patients at risk for respiratory compromise can allow targeted intervention for high-risk patients, whether that be preoperative respiratory optimization, which has been demonstrated to improve inspiratory and expiratory strength, or even preoperative interventions on the abdominal wall, such as pneumoperitoneum or chemical deinnervation of the abdominal wall with Botox and the external obliques, which helps possibly reduce the intra-abdominal pressure once the hernia has been reduced, and could be considered, especially for this high risk group. So being able to identify these patients is obviously important and something that we were able to do with CT volumetrics, but the question was raised, could we improve on this prediction? And that's where deep learning models came into play. So let's take a minute just to discuss deep learning and what it is. Deep learning is a type of machine learning, and it all falls under the umbrella of artificial intelligence, and that imitates the way that humans gain certain types of knowledge. And deep learning models can be taught to perform classification tasks and recognize patterns in photos, text, audio, and other various data sources. And it's also an important element of data science and predictive modeling. Where human brains have millions of interconnected neurons that work together to learn information, deep learning features neural networks that are constructed from multiple layers of software nodes that work together and enable computer to learn by example. To understand this a little bit better, I want you to imagine a toddler whose first word is dog. The toddler learns what a dog is and what a dog is not by pointing to objects and saying the word dog. And the parent or caregiver then says, yes, that is a dog. No, that is not a dog. And as a toddler continues to point to objects, he becomes more and more aware of the features that a dog possesses. And what the toddler is doing, whether he knows it or not, is clarifying a complex data abstraction, the concept of a dog. And so that's what deep learning is. It's attempting to simulate the behavior of the human brain and allowing it to learn from large amounts of data. So in order to put deep learning models into practice, we have to identify a clinical problem. In this case, we are looking again at pulmonary insufficiency after surgery. We have to collect that data, develop a model, internally and externally validate it, and then let the computer learn. So in our first ever study using image-based deep learning models, this was published in JAMA in 2021, we looked to see if deep learning models could predict certain outcomes after surgery and compared it to the predictions of expert surgeons. So we took 369 patients for a total of just over 9,000 images. And all of these patients had received their abdominal wall reconstruction at Carolinas Medical Center by 4 expert surgeons. And we were looking at 3 primary outcomes. The first one was surgical complexity, and that was defined by patients who needed a component separation. The second was surgical site infection, and this was defined as either deep or superficial wound infections, including mesh infections, and these are the same definitions used by the American College of Surgeons. And then pulmonary failure, defined as respiratory complications requiring transfer to the ICU for bilevel positive airway pressure intubation. And with that surgical complexity group, we set aside 25 patients, and we compared the computer's prediction of whether the patients would need a component separation or not based on their preoperative imaging to the predictions of 6 expert surgeons. This is an example of the type of data that was input into the DLM. This is a patient who ultimately needed a component separation, and these are obviously just 4 slices, but in order for this patient's hernia to be entirely imaged, they needed 22 axial images. So in this kind of schematic, it helps conceptualize, I think. We put the image into the DLM, and it's processed by these neuronal networks, and we get a binary outcome. Either the patient required a component separation or they did not. Did they develop a surgical site infection or not? And did they develop pulmonary failure after surgery or not? And these were the results. So before we go into this too much, I just want to kind of review area under the curve plots. So simply defined, an ROC curve is the plot of sensitivity over 1 minus the specificity. And that's for diagnostic test. And the area under the curve is an effective way to summarize the overall diagnostic accuracy of a test. It takes values from 0 to 1, where 0 is indicative of a perfectly inaccurate test, and the value of 1 represents a perfectly accurate test. And then the area under the curve of 0.5, this line right down the middle, suggests no discrimination, essentially a 50-50 chance that the computer is going to accurately guess the outcome. Furthermore, area under the curve of 0.7 to 0.8 is considered good. 0.8 to 0.9 is considered excellent, and more than 0.9 is considered outstanding. Okay, so with that background, for the surgical complexity model, where the computer was predicting what patients would need a component separation, it did very well at predicting with area under the curve of 0.74. Interestingly enough, when we compared that to the accuracy of our 6 expert surgeons, we found that the computer out-predicted them. That our accuracy of the DLM was 81% compared to 65% for the surgeons, area under the curve of 0.83 and 0.64. So that was a very interesting result there. For surgical site infection, the computer was excellent at predicting which patients would ultimately develop surgical site infection with the area under the curve of 0.89. But it had a harder time with pulmonary failure. And we think that that's because the DLM had a harder time identifying a rare outcome. So we kind of went back to the drawing board and set out to fine tune this model a little bit more. And that's what led to this article that was published in 2023 in Surgery that aimed to build on the prior DLM outcome prediction, but specifically look at predicting rare outcomes. And these models were trained using negative instances of an outcome, which were the majority of images. So essentially, we're teaching the computer who does well and asking them to asking it to identify the outliers. So this is a kind of a schematic of conventional DLM that we already discussed. Input of data, computer gives you a binary outcome. With Anomaly, which is the Generative Adversarial Network Anomaly DLM, it was designed to address two major concepts that had been applied to data science for imbalanced data. The first one was image augmentation, and the second one is anomaly detection. So image augmentation involves creating new representations of an outcome based on existing instances of the outcome. So the computer is essentially generating its own representative images to help it learn these rare outcomes. And then anomaly detection trains a model only using positive instances of an outcome and then recognizes images that are outliers as anomalies. So in essence, the Anomaly model augmented the training data set with artificially generated CT scans to enhance the model's ability to have representative images of these rare outcomes, in this case, pulmonary failure or mesh infection, and the exact number of the artificial images that is generated by the computer is unknown. But here are a couple of representative images, axial cuts that were rendered to the deep learning model. This is A is a patient who ultimately had a postoperative mesh infection, and B is a postoperative pulmonary failure patient. And you can see that in our large data set of 510 patients for this study with almost 10,000, or a little over 10,000 images, both of these outcomes were quite rare, with mesh infection only representing 3.7% of patients and pulmonary failure only in 5.7% of patients. But with this Anomaly model, we found that it outperformed the conventional DLM for predicting mesh infection with an area under the curve of 0.73. And it also outperformed predicting pulmonary failure with a much better area under the curve this time of 0.73. So the next step for any DLM is external validation. And so we partnered with Ohio State to attempt to do that. And we both brought a set of patients. You can see that our sample size was bigger than theirs. So we had quite a few more patients looking at component separation and surgical site infection again. And then also the other discrepancy to note is that the ratio of patients who received a component separation to those who did not is very different at these two institutions, kind of speaking to the idea again that a lot of the algorithms for treatment of these patients is not the same between institutions. But we pooled this data and we scaled the sample size to that of the Atrium models to make sure that the performance results weren't influenced by the fact that we brought more patients to the table. And we found that in our pooled data set, the computer was excellent at predicting surgical site infection. So why is this also important? Ultimately, we are setting out to help identify high-risk patients. So patients who are going to develop a surgical site infection after surgery. Those who are going to end up with a mesh infection or develop pulmonary failure. And the reason that we're doing all of that is to help try and optimize them pre-surgically. And for us, that means really aggressive weight loss, diabetes control with a goal HbA1c of less than 7.2, discussions about whether the patient may need preoperative Botox or pneumoperitoneum in order to give us a little bit more laxity of the abdominal wall, discussions about what types of mesh we're going to use, as well as patient selection and counseling, because we want our patients to understand possible outcomes and develop expectations preoperatively. I think that this technology can also help identify patients who may need component separation, because it may not be a problem at your tertiary hernia center, but there are general surgeons in the community who would not feel comfortable doing advanced component separation procedures. And if we were able to identify these patients early preoperatively, we might be able to get them to a tertiary hernia center where they can be optimized and potentially have a better outcome. And then ultimately, we think that this technology will help augment surgical decision making. I wanted to just show you, because I think it's really cool, on CT, how Botox and pneumoperitoneum can help preoperatively in patients with large ventral hernias. So this is some axial slices published by a group from Australia, but you can see the Botox is injected into the internal and external obliques bilaterally. And post Botox, you can see this elongation of the oblique muscles with an actual closure of the defect, or creating a smaller defect in the abdominal wall. And then in pneumoperitoneum, we're injecting air into through an intra-abdominal catheter that essentially acts as pneumatic tissue expander and gives you more room to reduce the viscera within the hernia sac safely without hopefully causing too high an increase in intra-abdominal pressure. And so, in a shameless plug to talk about what we do here at Carolinas and what I'm planning to do with the rest of my life, I wanted to talk a little bit about the importance of abdominal wall reconstruction programs and hernia centers. I think some of the main things that we bring to the table is surgical expertise. So these are really complex procedures and we do them all the time. So that's very important to have people who are familiar with these high-level techniques. We also have a high volume of patients, and we're doing this very regularly. We have access to multidisciplinary teams, including medical and surgical weight loss, geriatrics for pre-optimization, plastic surgery if you need, tissue rearrangement, and then nurse navigators to help patients both pre and post-operatively as they work through their hospitalizations. We also have standardized pathways with evidence-based practices, excellent patient education tools, and a continuous focus on quality improvement. This is one of Dr. Henneford's slides that I really liked, but it talks about this paper that was published called Artificial Intelligence, Machine Learning, and Surgical Science, Reality versus Hype. And the author says that the application of AI, or computer vision in this case, in surgery will likely not be a revolutionary process, but an evolutionary one. And you can see that, this process has taken time. And even as far as we come, we're not ready to bring this to the bedside just yet. We still need to continue external validation and get some prospective data so that we can know that this is ready for real time. And ultimately, the reason that we're doing all of this is to improve patient care at the end of the day. So with that, I will be happy to take any questions.
Great. Thank you very much, Dr. Mead. Any questions from our audience? I think Dr. Welsh had asked earlier in the chat about measuring subcutaneous fat. Is that right, Dr. Welsh?
Was interested in, they were talking about measuring in the three different measurements, but did they look at the thickness of the abdominal wall?
Not specifically at the thickness, but they did use the that computer program that I pointed out to measure the subcutaneous volume. So that essentially took into account the thickness of the abdominal wall.
Great.
Thank you.
Any other questions from the audience?
I had one other one. You mentioned about the pneumoperitoneum to get a little more room. How long prior to the starting of the actual surgery do you use the pneumoperitoneum?
Great question. So in the literature, it's not standardized at all. There's not that many centers that do this. And to be perfectly frank, I have not done it here at Carolinas, but I know you start several weeks prior to surgery, and generally it's serial insufflations of air to try and gain enough abdominal wall laxity.
Thank you.
Mhm.
Other questions? So I study AI ethics, so specifically the use of AI for clinical decision making. So I'd be curious about how you would incorporate an AI or machine learning model's prediction into the process of shared decision making with a patient, particularly if it influences your decision not to operate on the patient. How would you incorporate that into your discussion with the patient, particularly with an eye toward an unsupervised model that's not explainable?
Yeah, I think that's a great question as well. Obviously, moving forward, as I said, we're not ready to start doing this real time, but we do need to do some prospective studies. And in that case, we'd obviously be doing an informed consent process with the patient, and explaining, our process. And at the end of the day, in those situations, it would ultimately come down to surgeon judgment in the operating room. But I think that, I talked a little bit about this process augmenting our surgical decision making, and I think of it really as just that. So, hopefully it wouldn't ever be to the point where you're looking at the computer's data and saying, well, the computer told me absolutely not, we should operate on this patient, when my gut tells me that I think that they would do okay. So, it's something that can help us, but it's not black and white.
If I may, I would say this is, I mean, you can look at the various scoring systems that we use to judge the possible morbidity in patients. And this is what we would have to do with this as well, for sure. And except if you look at like wound complications, this is much more predictive than anything I've ever seen.
Right.
But indeed, it would augment us instead of replace us.
Yeah, it's a great discussion that's really being had in both the ethics and the legal literature now, particularly if these models become adopted as the standard of care for certain decisions. And so the place that it may put particularly surgeons in, and having a prediction, you can't not have it if you already know it, and then thinking about how to not only incorporate it into your decision making, but also the responsibility that you might hold for having had this decision, particularly if you don't act in accord with it. Dr. Jayaraja, you have a question?
Thank you so much. So, Dr. Mead, I had a question for you, which is how far in the future do you think it would be that we could use AI-based mechanisms to actually plan the abdominal wall reconstruction from an actual sort of geometrical standpoint? So, for example, vascular supply, looking at vasculature from a CT standpoint, and looking at sort of the abdominal wall reconstruction part. Hashtag Annie Benzie published a really nice paper looking at what we call the upside down tummy tuck, which is where we have these right subcostal horrible loss of domains, and we actually sort of pull the patient up. And having a 3D recon of how to best do that using AI, is that something that could be in the future or fairly soon, you think?
I mean, Dr. Hennifer could speak to this more than I can, but I would hope it's not too far in the future. There's obviously more data that needs to be collected, and as I mentioned, prospective studies, but yeah, I wouldn't imagine that we're too far away from that.
Thank you. I have a question as well. So as a community surgeon, my biggest challenge is when I have people come into my office that I've never met before. They get sent to me by someone that has not called me, not sent me their letter, and no CAT scan. And I can clearly see that they have massive loss of domain, Swiss cheese. And, I obviously have this, preoperative discussion, informed decision making. I actually use the Cedar app, and I have like some sort of tangible data to show them. But the biggest question I get is, well, how do I know that while I'm losing weight or while I'm getting my diabetes under control, how do I know that I'm not going to strangulate and this is not going to be an emergency? So at what point do you think the predictive analytics for strangulation of these hernias is going to come into play too? Because, doing a planned elective operation is very different than doing damage control in these patients. And do you think there's ever going to be a point where we can actually tell the difference between who is going to make it to that elective case and who is going to end up in the ER at 3 o'clock in the morning?
Yeah, I think that's a great question, and it's hard to predict a little bit. Obviously, we look at each patient on a patient-to-patient basis, and you're looking at a patient with a large hernia sac volume with a very small fascial defect. You're more concerned about that patient strangulating preoperatively than someone who potentially has a large defect. And so I think that you have to, currently we're using our clinical judgment, but I think that would be a great application of AI moving forward.
But if I may, if you were going to do that, it's a pretty uncommon outcome to end up in the emergency room. So it would have to be like these the models that we use where you predict pulmonary complications and also like mesh infection. But I totally get it. Who do you take time to prehabilitate, and who do you take the operating room? That would be a truly helpful question for us. No, absolutely.
Chicken or egg, right? Dr. Jayaraja wants to know about cirrhotics as well.
Because that seems to me like that would be the, multiply by 1,000,000 everything that we just talked about. Because, I just had one of these. I did a lab chole on a very well compensated cirrhotic that, just tried to talk him out of it, and everything is happening to that guy. So I just wondered what your thoughts were, Dr. Mead.
Specifically on performing patients on or performing hernia surgery on cirrhotics.
Yeah, I'm just wondering how that featured as heavily in the risk calculator.
Oh, yeah, I think there's obviously already multiple risk calculators for mortality after surgery and cirrhotics, and so that is kind of a risk in and of itself. That doesn't specifically pertain to risk of ventral hernia repair.
Any other questions for Dr. Mead?
And what about comparing this to NSQIP? Have you ever looked into that too? Because I mean, there are some like surgical site infections, postoperative respiratory failure, things like that. Like, how has that 500 patient kind of data set that you have? Probably if you pulled it from NSQIP too, to see if we should be actually doing things that are more specific in terms of the individual operations and diagnosis that we do, more than using that NSQIP calculator, because I use that all the time, and I usually use it to prove to people that I shouldn't be operating on them, which is rare. But it's really a good tool to have, and I think this is where AI is going to help our practices, but it's also for those patients that really need surgery. Then, we get to the ethics of that and the legal ramifications of that as well. And do you know, I guess, Dr. Binkley too, do you know of any kind of like either, like cases, ethical or legal, otherwise, where things like this have gotten, pulled into court, so to speak?
Yeah, it's a great question. I think something that I think is important to highlight as we're having this discussion about other predictive models like NSQIP is that evidence-based medicine is really many times relies on scientifically proven facts, or at least scientifically proven data. And AI just really relies on historic data, basically saying that the patterns that have occurred in the past are likely to occur in the future. And that's not always the case. And so, your hernia models, for instance, you take aggregate data from patients who've had hernia surgery, and their outcome, and you allow the unsupervised model to make the associations and make the predictions. In terms of how that will affect us going forward in terms of accountability, most legal experts, and I think Glenn Cohen at Harvard is the person who writes about this the most, basically says that if there are disagreements between surgeons and the predictive model, if the predictive model has been very well established and is considered at some point to be near the standard of care, then the surgeon would really have to go along with the model in order to avoid legal accountability, because you're judged in the legal setting based on how closely you complied with what's determined to be the standard of care. It's a little bit of a scary space, honestly, but that's at least what's coming out of the legal literature. I don't know of any current precedent that's tested that, but that seems to be where the legal theorists are predicting that things will go.
I think that because of that, hi everyone, this is Sharona. It is really important to what data is being placed into the algorithm of the AI. If the data is first needs to be a lot of it, and then quality data that will help predict accurately who should have it and who shouldn't. And so I think from that perspective, the collection of all the data and then applying the quality data is essential.
Absolutely. Any other comments or questions?
I find it interesting, Dr. Binkley, what you were mentioning about the perhaps hemming ourselves in as legally. When we first started thinking about this, I have said and will continue to say the best hernia repairs are repaired at home. Quality surgery done in community, support surgeons, support the community, support the family, support the hospitals. But a step up to a tertiary or coordinary care center, understanding when that should happen is important. But in the same breath, that could also be perhaps pinning people down, and they do operate on people in their home hospitals. Well, you should have sent me to a tertiary center. I appreciate that. Well, I appreciate what you say, but there are two things that I will continue to say every single time I lecture about something like that. And one is the first thing that I just said about community hospitals. And it's my responsibility to train good surgeons to do these operations. But secondly, I always will say, and every time we lecture about it, we hope that this will augment the good surgeon's thought process and not replace it. So every time I talk about it, I say that.
No, absolutely. It's so ironic that you're talking about that. I gave the surgery clerkship lecture this morning to our medical students on informed consent, and I presented a case in which some surgeons would have taken it was a Jehovah's Witness patient who was refusing blood transfusion, and I could imagine the scenario of some surgeons saying, I'm not going to take on that risk. And other surgeons saying, yes, I'm going to operate on him, even though he's refusing blood products. And I think it's a really interesting space that surgeons find themselves in sometimes, and having their own and being insightful enough to determine if they're the right person to do that operation. And if somehow we can augment their decision making personally, the idea of having each surgeon having their own predictive model that knows them and knows their skills and knows their outcomes and can actually help us maybe be more insightful.
That would be the ultimate in AI. If we can build a system where AI can look at your CAT scans and look at your patient population and tell you where your flaws are, and
yes,
perhaps we can operate on, that is the best. Absolutely.
Well, it's almost certainly going to be that each of us will have our own personal AI type assistant. But I think professionally, it'll be extraordinarily beneficial to have that feedback in real time. Any other questions? Another question.
Any of the fellows want to chime in? I know you're there. No, sounds good. Go ahead, Dr. Binkley. Sorry.
I was just going to ask a little bit about your data set for training these models. The models that I work with, that I collaborate on, they're usually trained on 750,000 or more unique patients with, we consider like a small data set for structured data, 10,000 data points. Were your models trained on the large data sets like that, or were these smaller data sets?
So based on my understanding of the papers and the methods, I presented the data and the sets that they were trained on. So compared to what you're doing, I would say smaller data sets.
Smaller data sets. I was collaborating with a surgeon, a plastic surgeon who does a good deal of extremity surgery, and we were trying to figure out what was the right number in order to have accurate predictions for rare diseases or rare associations. Thank you.
I will say one more thing is that if we do an app or do an AI for cirrhotics, it will lead to Johan 100%. directly go to him for surgery.
I'll let him know. He actually had to jump off, probably go operate on another patient with a MELD score of 400. So I'll let him know that, Dr. Hindenburg. Excellent. Well, thank you so much, Dr. Minkley. An excellent presentation, Dr. Mead. If everyone would mind, I just want to do a screenshot so we can tweet this out. So if you wouldn't mind just turning your camera on for a second. And Dr. Mead, can you go back to your first slide? And again, thank you all for a lovely discussion this evening. Obviously, this is something that we do like to be as interactive as possible. So moving forward, please feel free to use all the chats in the world. Sorry, I'm just screenshotting at the same time. And our next talk will be on October 16th, same place, 5 p.m. Eastern. The topic is neoadjuvant chemotherapy for resectable pancreatic cancer. So definitely going to look forward to that discussion. Hope everyone has a great rest of their evening and take care. Thank you.
That would be a great application for AI.
Very true. One day soon.
Bye-bye.
Take care. Thank you.
Thank you.